Malaria in pregnancy. Pregnancy makes women more likely to get malaria or die from malaria. Malaria infection is more severe during pregnancy, while pregnancy and its outcomes can become complicated by it. The effects of malaria on the pregnant mother include a severe form of the illness, anemia, miscarriage, preterm labor, and postpartum hemorrhage. A risk of to the fetus include fetal anemia, prematurity, intrauterine growth restriction, low birth weight, stillbirth, congenital malaria, and increased perinatal mortality. Preventive measures must be emphasized. That is insecticide-treated nets and intermittent preventive treatments in pregnancy. That's the IPTP. And ITNs is a insecticide-treated net. That's under direct observation. While confirmed cases must be treated promptly. So the main treatment objective is to ensure prompt and effective case management. Non-pharmacological treatment. Non-pharmacological treatment of uncomplicated malaria in the first trimester. You give quinine oral and may be given as monotherapy if clindamycin is not available, as 10 milligrams per kilogram with a maximum of 600 milligrams 8 hourly for 7 days, and clindamycin oral 10 milligrams per kilogram twice daily for 7 days. The drug of choice for uncomplicated malaria for pregnant women in the first trimester is oral quinine, and ACTs are not recommended for use in the first trimester. However, their use should not be withheld in cases where they are considered to be life-saving, or where other antimalarials are considered to be unsuitable. The treatment of uncomplicated malaria in the second and third trimesters. You give artesunate amodiaquine co-blistered formulation regimen for twice daily dosing, or the dosing milligrams per body weight is amodiaquine 10 milligrams per kilogram plus artesunate 4 milligrams per kilogram, taken as 2 divided doses daily for 3 days as after meals too, or artesunate or artemether lumefantrine oral or quinine oral. Treatment for severe malaria in pregnancy, that's all trimesters and puerperium, is artesunate IV or IM, and then ACT oral for 3 days, or quinine IV or IM, and then quinine plus clindamycin combination as oral. Treatment of severe malaria in pregnancy, second and third trimesters and puerperium, artemether IM, and then 3 days of oral ACT. Intermittent preventive treatment of pregnancy, that's IPTP, consists of giving the fixed dose combination medication, sulfadoxine and pyrimethamine in treatment doses at pre-defined intervals after quickening at 16 gestational weeks. And current recommendation is that IPTP with sulfadoxine pyrimethamine as IPT-PSP be given to all pregnant women at each scheduled antenatal care visit except during the first trimester. So WHO recommends a schedule of 4 focused antenatal care visits for normal pregnancy. National Malaria Control Strategy reserves sulfadoxine pyrimethamine for the purpose of intermittent preventive treatment only. To prevent the development of drug resistance, sulfadoxine pyrimethamine is not to be used for other purposes such as treatment of acute attacks of malaria. Sulfadoxine 500 milligrams pyrimethamine, 25 milligrams oral, and administered as direct observed therapy, that's DOT, during antenatal visits on at least 3 occasions and at most on 7 occasions. Let's look at the dose of the IPTP, antenatal visit, recommended gestational weeks, and the health worker to administer. So the IPTP1 is given at the first antenatal visit after quickening. The gestation week 16 weeks. And the health worker to administer will be midwives, medical officers, family physicians, obstetricians. And IPTP2 as at least 1 month after the first dose. Recommended gestation weeks is 20. And IPTP3 at least 1 month after the second dose is 24 gestational weeks. And IPTP 4 to 7 at least 1 month after each dose. This recommended gestation weeks is 28, 32, 36 and 40. So from IPTP2 to 7, the health workers to administer, midwives, medical officers, family physicians, obstetricians, physician assistants, community health officers, and also community health nurses. Pregnant women with the following conditions shall be exempted from using self-diagnose pyrimethamine. As first trimester of pregnancy, less than 13 weeks gestation, disease PD, enzyme deficiency, severe liver disease, or unexplained recurrent jaundice, known allergy to any sulfur drugs or allergy to pyrimethamine, history of previous reaction to self-diagnose pyrimethamine, recent treatment with the sulfur drugs such as tremozazole within 4 weeks, and post-date pregnancy, gestation beyond 36 weeks, breastfeeding, also acute case of malaria, owing to antagonism between folic acid and self-diagnose pyrimethamine. Folic acid supplementation should be delayed and started 1 week after self-diagnose pyrimethamine administration.